Right, good afternoon and welcome to this afternoon's session with Mr. Paul Trikha. What I'd like to do first of all is just introduce Mr. Trikha.
Hi everyone, good afternoon.
So thank you very much for joining us. He's actually joining us from Surrey, whereas we're based up in Manchester. Before we start, what I'd like to do is just go through some housekeeping rules first of all. So just in terms of how you communicate with us. So we have a Q&A function, and please can all the questions go in there. There is also a chat, but that's more in terms of any sort of technical questions or anything you have with regards to the webinar. So questions through the Q&A if we can. We'll answer those as we go through. If there's a pertinent point, I'll try and interrupt Mr. Trikha and get that question in. The other thing is the session is recorded, so any references or any information like that, there's no need to write those down. You can go back to the Academy YouTube and access those. There'll also be a certificate sent out at the end of the day today, and if you check your junk inbox, that sometimes goes in there. Some few people have also been asking if it can receive it as a PDF. All you need to do is click Save As and PDF, and it will then save correctly. Other things as well, there will also be a follow-up questionnaire, and also the references will be included in that email as well. So those will be sent through to you. So I'd just like to tell you a little bit of information about Mr. Trikha. He's a consultant trauma and orthopaedic surgeon specialising exclusively in knee surgery at Ashford and St Peter's NHS Trust, the Showing Clinic and the Surrey Orthopaedic Clinic. He qualified at St George's Hospital, London, and completed postgraduate training in London, South East England. He also completed his specialist fellowship training at the North Sydney Orthopaedic Sports Medicine Centre in Australia. He has a passion for teaching and is the training lead for Southwest Thames. Now, for today's session, he's really asked for this to be as interactive as possible. So do use that Q&A function, do get those questions in. But as you can appreciate, he's chosen two of the largest subjects within knees. So it might be a little bit of a longer session, but we think it will be really interesting in terms of how his approach has looked to maximise conservative measures in order to improve both patient outcomes, but also financial outcomes. And this can be particularly applicable as we look to re-begin services in the next coming weeks and months. So I'd just like to go over to Mr. Paul Trikha for him to start his talk. Thank you very much.
Cheers, Giles. Thank you. Okay, so let's start with ACL, child to adult. So we're going to start with a quick poll to see who's watching today. So Giles, if you could run that, thanks.
So we're just asking, what is your role, just to give us an idea of the audience and your perspective. Just really helps for the speakers. Okay, so we have nearly 80% of people answered. Just give that another couple of seconds and then I'll share that and go through the results. So as you can see, we have 5% consultants or doctors, 74% physios, 12% orthotists, 2% sports therapists, and 8% other. Okay.
Brilliant, thanks. So I always use this slide nearly every talk I do just to remind and refresh everyone the causes of blood in the knee following an injury are fracture or extensor mechanism disruption, and you can exclude that with a straight leg raise, ligament rupture, and in fact 65% of injured knees in children with blood in the knee is due to a ligament tear, a large meniscal tear, because we know the periphery of the meniscus has got a blood supply, and kneecap dislocation are the main traumatic causes. So the ACL history is typical. People will tell you they've torn their ACL, be it a non-contact twisting injury on a pitch, or a skiing injury where the bindings didn't release after a twist. They can't continue. They don't make it down the slopes. They may or may not hear a pop or a tearing sound, and the knee gives way. If they've got a straight leg raise, they're often X-ray to exclude a fracture. And it's a valgus rotation hyperextension injury. You've seen this image quite a few times, and this is what we're trying to control, particularly when we look at prevention later on. So this is a, I include this picture because now most semi-professional amateur games are videoed by someone on an iPhone, and it doesn't help. That video was only a grade 3 MCL. It looked like a posterior knee dislocation, and actually having the clinical picture does help when patients aren't sure what happened, but sometimes the clinical findings don't match with what you see on screen. I put this anterior drawing because people tend to use this. I don't tend to use this at all. It's difficult in the acute setting or in an acute knee clinic and doesn't add much value apart from potentially looking in this position for a posterior cruciate ligament injury. So I tend to use the Lachman test at 30 degrees. This is a patient on the right, 14-year-old ACL meniscal repair. The ACL's, the Lachman and the anterior draw is positive. The Lachman's very positive. And the pivot shift, you can hear, is quite a good going one. So a lot of knee surgeons talk about the pivot shift. It's our go-to test. You can do it awake, and I'll show you that in a minute. And what you do is you have a straight limb, you internally rotate the limb, this subluxes the tibia anteriorly, and mediated by the tension in the ITB, when you push the knee to 30 degrees, this anterior subluxation drops back, and you exaggerate that with valgus. So we'll just do that again. This is in an asleep patient on the left, pivot shift, and in an awake patient in clinic. Okay. You've got to look for associated injuries so you can clinically examine them. So this miserable triad of the MCL, medial meniscus, and ACL is pretty rare actually. In chronic presentations of ACL, you're more likely to get medial meniscal tears. In acute presentations, more likely to get lateral meniscal tears. Look for the MCL, and every so often people will miss the LCL in the posterior lateral corner. So I just want to mention the posterior lateral corner. A lot of people get confused. It's three structures: the LCL, the popliteal fibular ligament, and the popliteus. Apologies if you're having your lunch, but the dial test is what you do at 30 and 90. But just to show you this picture from Leprard, the posterior lateral corner is very easy. The LCL, straight down here. The popliteus, underneath the LCL on the femur, and the popliteus fibular ligament. Just these three structures with the ITB over. What investigations? Well, we do an X-ray, and people might see a Segon fracture here on this avulsion of the lateral capsule here. This is pathognomic for an ACL. And on the sagittal MRI scans, you can see the bone bruise and the anterior tibial translation, again, classical for ACL rupture. Acute management, you get full extension as soon as possible. Early flexion, ice the knee. There's no indication for draining a hemarthrosis. Brace any collateral ligament injury, and the only indications for an urgent arthroscopy is for a bucket handle meniscal tear, and if potentially there's an impinging ACL stump that the physios can't manage to get the patient straight with. So you want the knee to be quiet before you consider ACL surgery if you're going down that route, and you want the knee to be quiet if you're pursuing non-operative treatments as well, just to reduce the acute inflammatory trauma. Now, we do know that genuine copers with excellent rehabilitation, patients can do well with non-operative treatment. Most are unlikely to retain the same sustained level of activity, and we can discuss whether that's the case after ACL reconstructions. But with time, you are going to get more stress on the medial meniscus and lead to those medial meniscal tears and overload and potentially arthritis. Don't forget that the menisci offer a degree of stability as well. So if you tear your menisci or lose your menisci, you're much more likely to exaggerate your instability. We know that meniscal deficiency causes arthritis, particularly in the lateral compartment. If you lose your lateral meniscus, you're likely to develop OA symptoms or signs or X-ray changes within 5 years. We know if you chop out the meniscus and leave the ACL alone, that's probably the worst of all worlds, and you're almost guaranteed to get arthritis. Does ACL reconstruction prevent OA? No, it doesn't. But we do know chronic ACL deficiency with instability leads to complex meniscal tears not amenable to repair. This paper by Lars Engebretsen showed that per month with ongoing instability, you risk 1% chance of chondral damage. And these bone bruises can lead to late chondral injuries as well. In Sydney, where I did my fellowship, Leo Pinchesky's probably done 10,000 ACL reconstructions, I think now. He looked at his database and said that basically if you waited for ACL surgery, 5 months, your risk of meniscal surgery doubles, 6 times if you wait a year, and you can double those numbers again if the patient's under 17. So the goal of any reconstruction or non-surgical treatments is to achieve a stable functional knee to stop the knee giving way. From a surgical perspective, we want to stop the pivot shift, allow return to sports, and restore the kinematics so you can protect the meniscus and protect the articular cartilage. Okay, Giles, should we just do the next poll, please, on graft choice?
Yes, so this is a series of 3 polls. Now, Mr. Trikha, having watched some of our previous webinars, there was one where my knee was assessed. So in the case of a 40-year-old orthotist with a ruptured ACL, where would you take your graft from? Is it hamstrings, patella tendon, allograft, or quadriceps? The second question is, where would you take your ACL graft when treating someone of your parents' age, for example, so perhaps someone of 70 or above? And then where would you take your ACL graft from when treating a 15-year-old? Okay, so those are all coming through. Takes a little while when you've got 3 different polls going. Okay, I'll give it another 15 seconds. We're at about 60%. Okay, and I'll end it there and share those results. So you can see that in the case of me, for example, when treating a 40-year-old with a ruptured ACL, 73% said hamstrings. Where would you take your ACL graft when treating someone of perhaps your parents' age? Would be 37%. It's important to note that hamstrings was only 1% behind with 36. And then where would you take your graft from when treating a 15-year-old? 49% said hamstrings. The nearest to that was the patella tendon.
Okay, brilliant, thanks. So let's go through this graft, bone, patella tendon, bone. I'm surprised we're still discussing which is the stronger graft. All the grafts I discussed are pretty strong in terms of patella tendon or hamstrings. I suppose if you're looking at all the literature, you can err on the side of the bone patella tendon being more stable, but they do have more pain on kneeling and more patellofemoral pain. And taking a hamstring harvest compared to a bone patella tendon, there's more morbidity in the patella tendon. For the hamstrings, obviously you get some hamstring weakness, which takes longer to recover, and with time you can get tunnel widening. What about quads tendon? This was very promising for the last couple of years with good early results. However, the Danish ACL registry has shown that their early results showed a double failure rate in quads tendon compared to hamstring and patella tendon early on. In Austria and other centres, they're not getting those quite the same results, so we just need to keep an eye on the quads tendon and maybe curb our enthusiasm a little bit. Allograft's becoming very popular, and obviously we've got a knowledgeable crowd because particularly in the older population where we're not trying to get back to a high level of sport and they don't want to have the morbidity of a graft harvest, but it is costly and there is slower remodeling. So if you're not in a hurry, it might be an option, but in a young patient the re-rupture rates are significantly higher. So this is what an ACL reconstruction looks like. I draw your attention to this with view to the children's talks coming up. And on this slide here, we drill from this medial portal straight across here, and it's a tibial tunnel coming out just within the lateral, within the center of the ACL footprint. So what about shared decision making? This is important, and I wonder how many people actually generally go through this. We know that there's an increased chance of graft rupture in young active patients, young female soccer players, if the ACL is not put in properly, and the use of allograft. We know you can get back to sports if you've got a better chance, if you're younger, you're male, you've got a positive psychological response to training, and you use autograft. Clearly here it says the meniscus integrity is the most important, and an ACL injury does increase the risk of undergoing a knee replacement later in life. And here the literature does not support doing an ACL reconstruction to reduce the rate of knee osteoarthritis. So in summary, 81% return to sports, 65% to the pre-injury level. Meniscus and chondral damage is key in and their integrity in determining success in getting back. So people are trying to improve what we do with ACLs, and we know it's rotationally unstable, as we discussed, and the ACL is a central point, and there's been a lot of attention in putting something on the outside to further add rotational stability. This is the anterior lateral ligament, and these structures somewhere go between this area between Gerdy's tubercle and the fibular head, up to the proximity to the lateral femoral epicondyle. I mention this because there are two options. This is some of Leprade's diagrams, Robert Leprade. He's got a brilliant website if you need to go and look at any of these images. This is what an ALL graft looks like. It's usually a donor piece of tissue, or a gracilis if you're using just a semitendinosus. And it's somewhere between Gerdy's tubercle and the fibular head, and just behind the lateral epicondyle. In contrast, this is a tenodesis, which is the one that I use, where we take a strip of ITB from here and we roll it under the LCL, and just behind we use a staple here. It's quite a cheap method and a more stable method, and this has been proven by Alan Getgood from Canada, who this paper's Giles going to send out to you. He did a randomized controlled trial and comparing ACL and tenodesis, multi-sensor. The re-rupture rate was 11%. You think that's high, but the mean age is 19. And the re-rupture rate dropped to 4.5% with the tenodesis. I use it for all high-risk patients, young, female, patients with hyperlaxity, patients with a high tibial slope, all my revisions, patients with big meniscal repairs, and for key sports. This is from Al Getgood's paper. It's a small incision. We take a strip of ITB, we tuck it under the LCL, and with a staple, we fix it on the femur. So we know surgery can provide excellent stability. We know there's good evidence that early surgery protects against meniscal tears. We know that there is evidence that ACL reconstruction does not prevent future OA. And we know the worst thing of all is badly performed surgery. Complications, deep infection, and then loss of joint motion. Fat pad scarring, fat pad, the bane of everyone's lives here after surgery. It's very important we try and prevent this or treat this. Poor sighting of the graft on the femur, anteriorly placed femoral tunnels can cause restriction and flexion. Scar tissue at the front of the knee, cyclops. Treatment's not just more physio. It's important the surgeon and physios work together. If you can't get full extension early, we need to see the patients again. Reduced extension is part of the cyclops and obviously very important. And I'd like to get all my patients fully straight by 2 weeks and pushing for full flexion by 6 weeks. Prolonged immobilization will exacerbate this, and we're not to miss complex instabilities, hence the posterior lateral corner pictures earlier. So numbness in the shin. So this little saphenous nerve here. These are the hamstring area, the pes. This is your infrapatellar branch on the medial portal. This is where you can knock that off. And these bigger branches, when you take your hamstring harvest, come into play. So that's why they get numbness in the shin. These complex instabilities, so other than posterior lateral cord and MCL, if you do not attend to these and do the ACL, your ACL will fail. If you do not fix a meniscal root tear, particularly on the posterior medial side and a very unstable lateral side, then again, your meniscus is in effect defunctioned and your ACL will fail because the meniscus adds stability. You will have heard people talk about ramp tears, and it's just here, the posterior rim, the meniscocapsular attachment here. Sometimes you have to push your camera through here because you can't see this tear through normal portals. Andy Williams' group has shown that the ramp lesions can contribute to instability. A lot of surgeons say they haven't seen them, but they're there, they are there. So these tears occur in up to a quarter of ACL reconstructions, and they can make your pivot shift quite sizable. And you can't always see it on an MRI scan. Okay, ACL tears in children. So let's go to a little poll there, Giles, please.
Okay, so do you think that children should have ACL reconstruction? Simple yes or no. So this one's going up very quickly. It's important to note that if some of you are joining from a browser, you may or may not get these polls. So a few of you have mentioned that they don't always pop up, but that's why if you download the app, they will pop up. So we're nearly at 80%. So I'll stop that there and then share those results. So you can see that, do you think that children should have an ACL reconstruction? It's 68% have said yes and 33% have said no.
Okay, so there is an epidemic of ACL tears in children. I see a lot. It's growing, males more than females. 60% at time of presentation, by the time they've had a scan or got to surgery, sorry, have got meniscal tears. And in Australia, a close to 1,000% increase over 10 years in the number of procedures on the ACL. Why? Because people are competing more, there's more demands, they specialise in sports earlier, and we're all becoming more aware of these injuries, and we've got better quality imaging. So what are the risk factors? So obviously pivoting sports, any sports with problematic landing manoeuvres, it can be affected by your posture, your alignment, your quads activation, if your quad's dominant in women. Sex hormone receptors have been linked and found in the ACL, so they may be a factor. In women, you've got more chance of a higher tibial slope. You might have hyperlaxity with a high Baton score, recurvatum, and then you've got your sports, soccer, lacrosse, basketball, wakeboarding. If you're a regular wakeboarder, you've got a higher than 50% chance of tearing your ACL. It could be the pitch you plays on with coefficients of friction. It could be your cleats on your bike, and these all need to be addressed when you get back to full sports. It's important when we treat someone non-operatively, and non-operatively will involve a brace, and also make a very good one, the rocket brace. But it does have a huge impact in terms of content for your children and their physical activity, and that can lead and threaten their adulthood if they're not playing team sports. And if they develop meniscal tears in earlier way, we have a problem. And if you have an ACL in a 10-year-old who's prepubescent and they've got a lateral meniscal tear and they go on to develop OA by the age of 20, we have major concerns. So obviously children have unique anatomy. This growth plate, the physis, is important because you can damage it. We can damage it as surgeons. What tests? We look at the Tanner stage. It tells us how far they are in puberty, how much growth velocity they've got, how much, when the periods are going to be due. Well, we look at their laxity. Some people are just lax. It's amazing when people come and say they've torn their ACL and they're loose, but they're bilaterally loose. We try and estimate how much growth they've got left. So you can argue that rehabilitation for all children is an option, maybe the default option. And if instability persists, we can do surgery after skeletal maturity. We know that non-operative surgery, non-operative treatments can be viable and safe, but every single paper on ACL rehab versus surgery depends on having the highest quality of ACL rehab. And we know that with a rocket brace or an ACL brace and high quality rehab, you can stabilize the knee. So we have to weigh up the options of non-operative with high quality rehab and the risk of meniscal tears and articular cartilage versus operative and surgery and high quality rehab with the risks of surgery, which include leg length discrepancy, various valgus deformity, and re-rupture rates being high. So let's explore those. We know if you treat them non-operative, there's an increased incidence of repeated instability in children. Will not tell you that because they know it's likely to lead to a surgery because they will have had a consultation with a physio or surgeon. We know that up to 94% will not reach pre-injury level and up to 56% will not play at all. And the risk of meniscus and chondral injury is 6% a month, which is a lot higher in this age group.
Yeah. Sorry to interrupt, Mr. Trikha, but there's a question about sort of feedback about children's ACL injuries. Is there any sort of feedback on decision makers about children doing more younger? Is there any way to sort of influence that or prevent these in any way? Do you have any thoughts on that?
So prevention's coming in a few slides' time, so we'll get to that one. But in terms of feedback, I'm not clear in the question. And
I mean, I think it's more, is there any sort of, do you think it would be important to have input into child sports in terms of the level and progression of that?
Absolutely. I think it's becoming, obviously we have more major concerns in terms of pandemics, and I joked about the ACL being an epidemic in children, and it is. And we'll come to that in a second if that's okay.
Brilliant. Okay.
So if you damage the femoral tunnel in a child, they're likely to get a valgus deformity. People say they don't, but the risks are real if the surgery is not performed correctly. And on the tibial side, if you damage the tibial growth plate significantly, you can get recavatum or a leg length discrepancy. And if the tibial tubercle, if you happen to drill through this, you can get a change in the tibial slope. The risks are rare, but they are real. So general rules in the young, patellar tendon is not supported by literature. You're not meant to put bone plugs across the growth plate. In America, in particular, drilling across the growth plate in the femur is not supported for prepubescent children, TANA 1 or 2. We shouldn't put any screws across the growth plate, and we need to follow these children up. And we shouldn't use allografts in children because the failure rate's 4 times. So when someone's TANA 3 or 4, they pass puberty, we can treat them almost like an adult, but with a more careful surgical technique, more appropriate surgical technique. And we use a soft tissue graft as mentioned. But this is a picture I used earlier for the adult ACL. And if we do that in a child, we are going to go straight and shear across the growth plate here. So there is a potential to use a more traditional ACL, which is vertical, and go cleanly, minimally across the growth plate here. In TANA 1 or 2, the very prepubescent children, we don't want to go across the growth plate, and this is the group I tend to consider ACL repair rather than reconstruction, and I'll talk about that in a second. This is one technique from Min Kocher, Kocher, from, I think it's Chicago. He takes a strip of ITB from here, over the top position, under the intermeniscal ligament, and ties it here, avoiding drilling through the growth plate. The technique I prefer to use is this yellow. They're all epiphyseal drilling, okay? And that's safe for the growth plate. Okay, a bit like this. So everything below the growth plate here and above the growth plate on the tibia. What about living donor? So in Sydney, this is where we train Leo Pincheski. has looked at this. He knows that pediatric ACL reconstruction numbers have gone through the roof, and they're at higher risk of failure and a repeat ACL injury, and their grafts aren't very good. So they did a big study on living donor, no donor site morbidity, you don't need to screen because it's from your mum or your dad, predictable graft size, and the hamstrings are there if you need to revise or redo the surgery later. Myself and Adrian Wilson did the first case in Europe on an 11-year-old using hamstrings from the mum. And this is the case. We did outside-in drilling, and you can see we drill below the growth plate. The growth plates don't look that open, but they are. This knee is flexed. And what about ACL repair? So reconstruction is the gold standard, using auto graft, hamstring, patella, quads tendon, and you use a graft to replace the ACL. This is a reconstruction. An ACL repairs or fixes back the torn ACL without using a graft, and you can use much smaller tunnels. This has been rejuvenated. All the early ACL repair procedures failed because there's a lot of synovial fluid, the knee moves, and you can't get a good stable clot in the ACL. The techniques are changing. The advantage, if you can repair it, particularly in a younger person, you might get them back to sports for four months at the earliest, and you don't burn any bridges. So I tend to try and repair with appropriate consent my prepubescent children. Final decisions are arthroscopy. And the reason it's working now is we're not just sewing the ACL back, but we are protecting it either with an internal brace or this ligament system, which is common in the States. I mean, in Europe. In the States, they're using the bear technique with Martha Murray in Boston. And this is in essence, on this picture here, you've got the internal brace, you've sewn the ACL back, and you support it with this fiber tape, and here again with some suture and the ligament system here. Early results from Scotland were good. However, this paper showed a 48% failure rate at 3 years in adolescents with ACL repair. So we need to be very cautious of who we do this surgery. So high failure rates in children, Leah Pinchesky, 20% failure rate. You're 4.6 times more likely to fail. These papers from Shelbourne, high failure rates in under 18s. And the Danish registry, high failure rates in under 20s. And that's why in children, I do a tenodesis in all my kids. And instead of putting a staple here across the growth plate, I'll take the ITB, wrap it under the LCL, and sew it onto itself down here.
There was a question about ITBs, Mr. Trikha. In terms of ITB donation techniques, is the ITB sewn back together, and is the ITB donor site an area that you might get future problems, perhaps?
Okay, yeah. So people doing tenodesis, we tend to say it's just a quick procedure on the end, but that wound on the outside where we do a tenodesis, you've got to be meticulous with your hemostasis. They can get hematomas, so you've got to ice and close that wound properly. I closed the ITB just to make sure you don't get a muscle hernia, but I think Andy Williams' group, they looked at that, and you can get a muscle hernia. You don't have to close the ITB, but people don't like the muscle herniation if you do get it. What was the other question, Giles?
I think you've covered it, actually. It's just in terms of, yeah, you have covered those. Yeah, thank you.
Okay. So, non-operative treatment for isolated cases should be attempted in everyone. If you get ongoing instability, you're much more likely to develop meniscal tears. So then you've almost got an obligation to reconstruct the ACL. If you have ongoing instability, managing and treating a growth disturbance is more manageable than treating a 20-year-old's knee with no cartilage or no articular cartilage. Quick few slides on rehab. Most of your physios have seen. So go slow on the children. They're not going to go. It's frustrating the first month. They don't want to get that swelling down as much. Extension might take a little bit longer. They're children. We have to be a bit more patient at the beginning. if you've done a meniscal repair, brace them. I know some surgeons are saying they shouldn't, but absolutely, why would you not protect your meniscal repair? We know on deep squatting, your meniscus overrides the back of the tibia, particularly on the lateral side. If I'm doing a lateral meniscus repair in a child, that's them 3 months in a brace. If you need to limit them or protect a meniscal repair, that's where I use the unloader in younger people. So quick summary on my principles for rehab for adult and children. There's good evidence to support accelerated rehab, not to restrict range of movement, immediate range of movement, immediate weight bearing where possible. I'm happy for open kinetic chain between 45 to 90 degrees from 6 weeks, 0 to 90 from 6 months. Happy with early closed chain. And no one gets back to sport. Minimum 9 months, minimum. It's not a time thing. It's muscle strength thing and passing return to testing, return to sports. If you're younger, it's going to take a bit longer. You've got to pass end stage testing. You've got to be psychologically ready to go back, and you've got to be engaged with a rehab program and a prevention program for the following 20 months, 24 months afterwards. So we, as pediatric ACL surgeons in particular, have an obligation to encourage injury prevention. And we can control their biomechanical movement, and that's where we all come in. It's a key modifiable risk. And we want to try and reduce this peak dynamic knee valgus we talked about, looking at hip adduction, internal rotation, knee valgus, concentrating on landing maneuvers, and try and control this knee valgus and rotation. How? By biomechanical adaptation, range of movement strength, plyometrics, coaching, strength and conditioning, warm up, and this is very important, and we need to do a lot more in schools. And the schools are resistant and reluctant. It takes 20 minutes to do these, and with games lessons, I don't know whether we need to be more forceful encouraging this. Neuromuscular training, plyometrics, biomechanics, strength, balance, core stability, as we discussed. And the FIFA 11 Plus and the PET programs have shown you can reduce 50% in non-traumatic injuries in the lower limb, and the Australian Institute of Sport have their prevention programs as well. This will be there on the system. You can look up PEP by Tim Hewitt and the Scandinavian programs as well. And I think I'll pause there, Giles. So we've got any questions on ACL?
So there were a couple just in terms of you mentioned about not performing surgery on a hot knee. Roughly how long does that take for that knee to settle?
Anywhere between 2 weeks and 6 weeks, depending on physio input. I'm a big believer in physiotherapy, as you all know, and prehabilitation is vitally important. So if you can get any prehabilitation, that's really useful. I know in the NHS that's not available, but Ashford St Peters, they're doing a study on that now as the higher numbers come through and to try and get patients ready. So typically the earliest will be 2 weeks. 6 weeks would be a reasonable way to go, but you need the knee quiet. Yeah, so that's the answer there.
Okay, and with regards to timeframes, David Barton asked, how quickly do you need to have assessed a child for repair? Is after 6 months normal in the NHS pathway? Is that too late, or what are your thoughts on timelines?
So I have a pediatric knee list, so my children do get preferential treatment because of the way my operating lists work. So they're never going to wait more than a month for me, depending on capacity. Yeah, so for all my children's ACLs, actually, I have an MDT approach, so for isolated ACLs. So we work out with me and the physios whether the patients are going to be genuine copers or not, can we manage, and we have to weigh up all these growth issues we discussed. So privately, NHS, MDT approach to all my children's ACLs. For isolated injuries, are much more likely to go down the surgical route if they've got increasing meniscal tears or chondral injuries as well.
Okay. And one last question on ACL. It's from Alison Rippendale. Is the ACL repair for avulsion injuries only, or would that be, would you utilize that in mid-substance tears?
So I only utilize it in prepubescent children, or Tanner 3 maybe, if they've got a full thickness ACL avulsion and they've got good tissue there. So at those procedures, the patient is consented for another reconstruction type of procedure at the same time.
Okay, right. Thanks very much. So if you're okay, we'll go on to the OA knee evidence-based treatment in that section.
Okay. So some of you may have seen this chart before. What we're trying to do is disease progression on the vertical axis, time on the horizontal axis. The green procedures, this is all surgery, but over here, right at the beginning, rehab, rehab, rehab is the most important thing. And we're trying to stop patients in this age group, this repair group, getting significant damage while they're young, the treatment gap, okay? These are the pillars. So at joint first place, rehab with physiotherapy and alignment. You know, if you're varus valgus, you're in trouble from day one. If you don't do rehab from day one, you're going to be in trouble. Ligaments are very important, but not as important as these. The meniscus, you can repair your meniscus all day, but if you've got poor alignment or poor stability, it's not going to work. And the same with articular cartilage problems. So the philosophy, physiotherapy, osteotomy or an unloader brace, get the alignment good, stabilize the knee, ligament reconstruction or brace, repair or replace the meniscus, and deal with the articular cartilage. There's a new boy in town, and that's biology, and we'll touch on that as well in terms of injections. Quick note on meniscus. I know I'm trying to cover the whole of knee surgery in an hour, so I just want to just really hone down on meniscus, because a lot's been said about meniscus surgery for the last couple of years. Ian McDermott's paper, OA risk 14 times if you chop out the meniscus, much higher in lateral meniscus disease. Degenerative meniscus, no history of trauma, slowly develops, often incidental finding. These ear X-ray, your scans, starts off with a bit of signal, becomes a horizontal cleavage, degenerate tear over a couple of years. We know by operating on these, if you've got high body mass index, it's lateral meniscus, you've got chondral damage, bone marrow edema, meniscal extrusion, or if you chop it all out, the patients are going to do badly. Which is why ESCA produced these guidelines on treating meniscal tears, and particularly for non-locked painful knees, which are degenerative, the emphasis is on non-operative treatments. This is the Basque guidelines, which I prefer. Locked knee surgery, is it indicated to repair the meniscus? Surgery, everything else is non-operative, okay? So all traumatic tears, in my opinion, in a blood supply area should be repaired, okay? And we know this because the meniscus is a blood supply, and if it's a big tear like this, with a blood supply, we should fix them. And to summarize meniscus, if you look at the shoes first, a degenerate meniscus, a degenerative shoe with flaps of chondral surface and flaps of meniscal tissue, a tear like this, there is no such thing as an urgent meniscectomy. You do not need to do it, okay? You can take your time. Sometimes these meniscal tears can be trapped and we need to treat them surgically, but not if they've, not urgently. They can always go non-operative first. If your brand new pair of boots or your loafers and the heel comes off, you're going to fix it back. Traumatic injury, consider fixation, particularly in children, and particularly on the lateral side. Degenerative, you've got all the time in the world. What is OA? OA, so the biggest factor for OA is prevention. That's by not chopping meniscus out if you can help it, and preserving the meniscus and stabilizing the knee. Okay, so OA, 50% of over 65-year-olds are affected. Half of all OA consultations are for knee. The numbers are going through the roof, and obesity rates are linked, and there's a huge financial cost. We know facts that regular physiotherapy and physical activity works. There's no more evidence required. I think Mike Callahan did a webinar earlier. You can have a look at that on the Össur website. It's proven to work. And this is the degenerative cycle. You need to interrupt this in two places: deformity, mechanical dysfunction, target loading, articular cartilage damage, pain and swelling, quads inhibition, contractures. The pain for muscle inhibition, obesity leads to overload, reduced range of movement, flexion, contracture, muscle atrophy, joint stability, cardiovascular ability. These all need to be addressed. This is your NICE guidelines. Bang on, most important: education, strengthening and exercise, fitness and weight loss. Please, 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 we all have to share the weight loss conversations. They're unpopular with the patients, they don't like it, but we all have to share that with them, not just the surgeons, the physios, but whoever else is seeing the patients as well. Lifestyle advice is important. Anyone who works with me tells me, I should have my own exercise bike shop or turbo trainer shop, because nearly everyone gets recommended to use one. And the NHS stats for exercise prescription are clear, not just in OA and hip fractures and orthopaedics. For everything, depression, dementia, exercise is really good. I think if we limit everyone's exercise to 1 hour a day, like we have done for the last few months, I think we'll get a lot more people doing some exercise, because it seems to be working and everyone seems to be outside. 3 major components: aerobic exercise, reduce your weight, cardiovascular health, flexibility, get that range of movement. This is going to be repeated in this talk a lot, and get strength. Okay, don't get bogged down with this side. The important things is it's 3 times a week is the ideal. Once a week, the evidence is pretty weak for physiotherapy. 3 times a week is pretty good. That's quite hard to deliver. Physiotherapy should be individualized and supervised, and not given as pieces of paper with some exercises to give. And this point about reducing, improving extension, that should be, you want to get full extension as soon as possible by reducing your fixed flexion deformity, and we'll touch base on that. So, fixed flexion. Fixed flexion is never good. Pre-surgery, post-surgery, anything to do with knees, fixed flexion needs attention. Giles, do you want to go to that poll for me, thanks?
Yeah, so what treatment would you suggest for a 70-year-old patient with OA, an 8 out of 10 pain score, and a 10-degree fixed flexion deformity? Is it non-operative, physio or rehab, or operative, total knee? Okay, so we have about 50% have answered, nearly up to 70%. And I'll just leave it a few more seconds and then share that. So we're up to 80% there. I'll just share that. So in terms of what treatment would you suggest for a 70-year-old patient with OA, 8 out of 10 pain score and a 10-degree flexion deformity, 57% said they would go with non-operative physio or rehab, and then 43% say they would go with a total knee replacement.
Okay, so let's try and change that to 95% non-operative, because that's what I would be doing. The only ones who are going to get primary knee replacement are people who failed non-operative treatments. So why is that? So we know there's a huge number of total knee replacements. We know 20% of people who have a knee replacement are not happy. And most patients deep down do not want to have that surgery. If you have one bad knee, you're only as good as your worst knee. And sometimes they present with symptoms that have only been there for a few months. Rehab, brace, painkillers, injections, wait, then total knee replacement, regardless of this fixed flexion deformity, and I'll explain why. Because there's some myths associated with OA. One of the myths, or the 3 myths, is get strength, quads VMO, get strength. That's what you'll get all the junior doctors and inexperienced surgeons writing on the request forms. Increase strength, take it easy, give up all your running, give up all your exercise, give up your impact, and your flexion contracture is fixed. So myth 1, increase strength. No, you need to get your motion back. You need to get the motion back. If you get the motion back, you get the pain down, then get strength, and you can't strengthen a stiff knee. Number 2, adjust lifestyle, take it easy. No, pain gets worse. Whatever that perfect amount of activity in terms of walking and running, there is a perfect amount. You can run too much and wear out your knee and it hurts. You can do too little exercise and you get the same effect. Do not take it easy, you need to exercise. Flexion contracture is fixed. This can be reversed. It's hard work and it involves a lot more physiotherapy. We do not often see good symmetrical extension at total knee replacement because people who have good extension don't have the pain associated with severe OA that needs total knee replacement. You need full extension for your VMO to function normally. We all know people who've got really, really arthritic knees with a good range of movement who do well. And the worst case by regaining range of movement is you get better results after your total knee replacement. Do whatever it takes, towel stretch, maybe don't push down, it hurts. There are extension devices you can use and buy, but the key is to regain lost range of movement starting with extension, getting that VMO working, getting your knee stable, get your hands on the patient when you're allowed to do that again, deep soft tissue work, tight posterior capsule, look at your hamstrings, gastroc fat pads, do your patellofemoral mobilizations, do your prone leg hangs, your home stretch routine. But most of you are physio, so you know all this and all of those. So OA rehab, get extension, get extension, get extension, then get flexion, then get strength. Use a steroid injection with us or whoever you give them to do those exercises and to get that extension, flexion, and strength. Shelbourne used that above approach and looked at 207 patients. 90% had moderate and severe OA. Only 15% went on to have a total knee replacement. So let's talk about supports and braces. I have no disclosures for this talk with regards to Össur. We have proven that mechanical adjuncts work, from a shopping trolley to a neoprene brace to the unloader. And we know that improving your biomechanics, a lateral wedge orthotic can shift from a medial-based axis, from a very medial-based axis back into the knee joint for varus. So they're good. And we know that the unloader does the same. So here you've got a medial joint space distraction and the joint space recovers. How do these work? They distract the compartment. Sorry. They reposition the damaged force into the good areas of the knee. They reduce the compartment load, reduce the moment force. They actually increase the bone density in the opposite compartment, so we know they're working. Increase proprioception. There's been studies to show that it doesn't cause muscle weakness, but you do need to wear them. If you don't wear them, they won't be effective. Paul Lee's shown them to be cost effective in looking at 63 patients over 8 years. Briggs and Kirkley have also shown functional gains and benefits over a neoprene brace. So we've been using it at St Peter's in the NHS for a while, and this paper is finished. Lucy Oliver Welsh, one of our registrars, has written this up for us. We looked at 509 patients over 5 years, mean 3 years, minimum 1 year. 83% had an OA grade 3 or 4, and 80% have not had surgery, and 15 have come off the waiting list. So these are the numbers of our knee replacements. The blue is what we did in 2014-15 compared to the national average. Okay, so we used to be higher than national average, and now with a non-operative treatment protocol following the best guidelines and the use of the unloader in particular, we have reduced our number by 141 compared to average, but we were above. And just looking at average, we have saved over the last year close to £1 million. And then surgery, so it's evidence-based. Knee replacements do work, and it can be an osteotomy, partial knee or total knee. We know, though, that 20% of patients after knee replacement are not happy. Okay, it's a real number. 10% amazing, run. I'll show you some of those. 20%, 1 in 5, not happy. Okay, I use the medial rotation knee, made in Ashtead in Surrey. It's the MRK. It has the lowest revision rates of all knee replacements on the NJR. The PROMs are better than all knee replacements on the NJR. The more patients forget their knee than any other on the NJR, and more patients are satisfied. My mum has 2 of these in. She's had bilateral knee replacements. And this is why, because this is my patient. This is a 90-year-old at 2 weeks. Okay, this lady's 11 days after her total knee replacement. Okay, and at 6 weeks, I get all my patients to run down the corridor. Some people, he came back for second side. That's why he's showing off. And the rehab can be pretty impressive. This guy's had a left knee replacement. And what this picture in particular shows is complete stability.
You ready? Turn and go, mate. 3, 2, 1, let's go. Push.
Okay. Any burning questions, Giles, there before I finish off on injections?
There was just a question about repeated steroid injections and what are your thoughts with regards to advice on denaturing effect on the cartilage?
Okay, in 3 slides, I'll answer that question. Here we go. So what are the injection options? You've got biological, PRP, HR, HAME, stem cells. There's some new ones, interleukin-1 antagonists and stuff. And non-biological, steroids, anti-inflammatories, local anesthetics. Steroids work by being anti-inflammatory. First line treatment for me in terms of injections, if you have one every 3 months, you're going to get steroid-induced osteopenia and cartilage loss. If you're likely to have a total knee replacement in the next few months, then it's not wise to have a steroid injection. I think that hopefully answers the question. HA has been shown to replace the disease synovial fluid, reduce pain and function, but it's not recommended by NICE, American Academy, strong recommendation again against usage, but the people who believe in it say it might reduce the need for knee replacement for a few years, but there's no evidence to support that. This paper looked at intra-articular saline versus HA, no difference. What about biologics? So all those I mentioned, and these are coming because HA and steroids don't have any long-term relief. Okay, so the options here, PRP, bone marrow, aspirate, fat cells, lipogems, fat cells, and then these newer agents. Stem cells are a controversial charged term. There's adverts in every paper in London now, US as well. And these injections are all available, including amniotic tissue and placenta-derived tissue. There is no data in living tissue, in living people, and there are no live cells being transferred. So they're not mesenchymal stem cells; they're medicinal signaling cells, and these stem cells are meant to be cells that are able to differentiate into other types. I.e., in this picture, they're capable of differentiating into bone, cartilage, muscle, marrow, tendon, adipose, or connective tissue. But to do that, to make them differentiate, you have to manipulate them, and manipulation is forbidden in the UK and the US, but there's some global clinics in the Bahamas where they're allowed to manipulate them for some reasons. Okay, so unless you're allowed to manipulate them, you can't make them differentiate, is the point I'm making. Okay, summary on biologics. There is no evidence. There's no evidence to show it reverse the progression to OA, and there's no treatment showing any joint preserving properties, but we do know they may have a mild anti-inflammatory role and they might be safe. PRP is platelets containing growth factors and cytokines. Works anti-inflammatory wise. You can inject it into the knee and it can produce an increase of hyaluronic acid, reduces this bad boy. and can reduce medicinal signaling cells from the cartilage surface. You can get leukocyte poor, leukocyte rich. There are hundreds of different types of PRP. So having a PRP injection means nothing unless you know what you're injecting. 10 positive RCT trials shows that it's better than hyaluronic acid and better than placebo. However, only better WOMAC scores in leukocyte poor PRP, no difference otherwise. This 10 randomized controlled trial review showed 8 out of 10 had a high risk of bias, and nothing shows any results more than 1 year in terms of pain relief. So at best, short-term pain relief, possibly improvement in function. No evidence to show slow or reversal of OA. Same for bone marrow aspirate. No difference comparing stem cells and bone marrow in a one single blind RCT. And then fat stem cells. We know fat stem cells are relatively safe, although this Radio 4 stem cell hard cell, it's on the iPlayer if you want to have a listen. You do well to have a listen. Not all the risk factors are out there. There are some adverse events, but there's been no improvement radiologically and no no improvement and no cartilage reversal with fat stem cells. No high quality evidence. They may serve as short-term palliative options. This paper's on the reading list, will be sent. It's from ISAKOS February 2020, looking at the biological approaches and current concepts. None have been proved to show disease-modifying benefits. And just while we're talking about PRP, just in orthopedic sports medicine, I'm a sports knee surgeon. Okay, this paper reviews the PRP in everything. Tennis elbow, some relief up to 24 months. Patellar tendinopathy, no improvement. Achilles tendinopathy, rotator cuff, muscle injuries, plantar fasciitis, meniscal tears, ACL repair, patellar tendon donor site, no difference for PRP. PRP might provide some benefit in knee OA, lateral epicondylitis, tennis elbow, and ulnar collateral ligament injury. In the rest, no proven benefit. And then that's my contact details. If any of you want to join me in clinic and theatre, and my contact details are there. Thanks, Charles.
Brilliant. Thank you very much. So there are a few outstanding questions. So one from Andrea Ronca. What guidelines do you use for total knee replacement rehab?
What guidelines? That's a good question, because I don't particularly use any guidelines. I get the patients moving as quick as they can. I use a combination of, again, the rules about extension apply. I get them early. I use cryotherapy early. I try and recommend that to all my patients. Physiolab in particular is very good. Get the swelling down, get the extension. I don't limit them in terms of activity. I warn them against running as a hobby, but I allow them to do a little bit. It makes them feel alive again. They enjoy that aspect of it. So I don't limit them at all.
Okay. What are your thoughts? It's a question from Janet Lawrence. What are your thoughts on lateral unicompartmental knee replacement in a young active patient, 40 years roughly, who has no evidence of medial compartment OA?
So I think some reasonable results for both lateral compartment and medial compartment unicompartmental knees. I think any kind of joint sacrificing surgery in anyone should be the last resort. And using those measures we discussed in terms of getting range and getting the pain under control and giving the patient a better understanding of their pain is much more important. But is it a viable option? Yes, it is.
Okay. And just with regards to at the moment, a question from Jack Bain. With regards to COVID-19, are you currently injecting knees? And if not, when are you hoping to return to that?
So yeah, there's a link that if you have a steroid injection during this time and you were likely to, and if you went on to develop coronavirus or COVID symptoms, it might exacerbate these and make these worse. But so it's reserved, I think, at the time being for people who are pretty bad in terms of having an inflammatory pathology, severe OA associated with inflammation within the knee with appropriate consent.
Right. Okay. And there have been quite a few questions about glucosamine and in terms of its effect on patients perhaps 40 and above. What are your thoughts or recommendations on patients taking glucosamine?
Again, like hyaluronic acid, there's people out there who swear by it. It's not proven to be of any benefit. It might work as a mild anti-inflammatory, but they're quite expensive mild anti-inflammatories. I think taking them for 3 months is reasonable. If you think it helps, it helps. But I don't tend to recommend taking glucosamine or chondroitin.
Okay.
I don't discourage patients from taking it. If they're taking it and they like it, then fine.
Okay. And with regards to osteotomies, HDOs, when are those recommended, and what are your thoughts with regards to those?
Okay, so if they've got malalignment, be it the femur, the tibia, we need to work that out and analyze that properly. Again, in that patient, the 40-year-old with a lateral uni, you know, if the rest of the knee was preserved, I'd be thinking more likely to go down the osteotomy route if they've got malalignment than replacing the knee. But interestingly, they're bang on the right guys to try a lateral unloader in to see if they're going to do well with surgery. If I'm doing any osteotomy or any uni, I'll try them in an unloader first, and then if that works, keep them in it. But at least we know it's a good trial and test to see if your operation is going to work.
Okay. Going back a little bit to the ACL section, but how can we minimise rotational instability post-operatively? Do you have any sort of procedures for that?
So I use that lateral extra-articular tenodesis in all my high-risk patients, as mentioned. So that's probably over 30% of my ACLs now would get that procedure. And obviously you need to attend to repair your meniscal roots, repair your meniscal ramps, deal with your MCL, deal with your posterior lateral corner, and if you fixed any of them, protect them in a brace.
Okay. And on the subject of bracing, I think Mike Callahan covered this a little bit, but Kunal Vashust was asking, will braces promote any dependency which might interrupt the rehab, for example?
No, but some of the papers on this brace and says that if you wear it more than 2 years, you're probably not going to go on and have a knee replacement. That's the midterm results of this. So we've proven that the braces don't inhibit muscle control. That's the question. That's been proven, I think, in a couple of papers, and I'll refer you back to Mike Callahan's talk on the Össur Academy website on that.
Okay. So thank you very much. Really interesting. There have been a lot of questions. There have been a few questions saying, why hasn't mine been answered? But as you can understand, we have 500 people watching. So we'll try to get through as many as we possibly can. Just really remains for me to say thank you to Mr. Paul Trikha. Fascinating talk. Two very interesting parts to this. So very much appreciated. We will be returning to our weekly slot, but we would like just to have some idea of what time is best for you guys. Obviously, it's a very dynamic situation that we're currently in. So if you can just fill out the poll, and then hopefully we can try and aim to get these future webinars at a time that suits you all as attendees. So I'll just keep that up for a little while longer. Brilliant. And I'll stop that for now. Really, thank you very much, Mr. Trikha. It was a fantastic session. The next session next week is being conducted by Mr. Sachin Ahuja on management of spinal trauma. Same time again, it's on Wednesday at 2 p.m. and a fascinating talk there. So I hope you can join us here next week. Thank you very much.